Thank you. Thanks for joining Tracy and me at 3:50 on a, what day is it? Tuesday? Tuesday afternoon. I see familiar faces in the audience and a lot of new faces, so I'm very happy to welcome you all to this part of the conference. Tracy and I worked together for a year at Columbia and still take care of a good number of families whose children have epidermolysis bullosa. Now, let's see, I should start by pushing this arrow to the right. So Tracy and I don't have any conflicts of interest, financial relationships, and I mentioned many off-label usages of medications. So one of the most frequent questions I get when I first speak to a provider who's never taken care of a patient with epidermolysis bullosa or a family who's just found out about the diagnosis in their child and wants to come in for consultation is when and where is the pain going to occur, and then as they begin to learn more is when and where does the itch occur. And I usually start by talking about the things that are most apparent to them, which is the episodic, or what I call episodic pain with dressing changes and baths. And as I've talked to families and patients over time, what's painful about the parts of the dressing changes is usually something of curiosity to clinicians and also to families. The exposure to air can be very painful. The lancing of the bullae can be very painful. And I've also tried to learn from the kids as they grow older which parts of the bath can be painful to them. The washing, the entry into the bath, the getting out of the bath, drying, and the different additives that go into the water can cause them different levels of pain. For example, vinegar can make the bath more painful, and other things within the bath. The other types of pain that families get to know quickly are areas of mucosal involvement, so anywhere in the genital area, anywhere in the eyes, anywhere in the mouth, and the exposed, or what I call vulnerable areas to trauma, whether that's skin on skin within the child, or hi Kim Morrell, I haven't seen you. Welcome. All these nice people from Columbia. It's like kind of being in Washington Heights. And what I call vulnerable areas, so skin on skin in the neck, as patient gets older, their knees might rub together, and then the areas of trauma, for example, the ears, the nose, the face, the fingers, the hands, the toes, feet, knees. And also, as I talk about episodic or variations in pain during the day, I also talk about variations of itch during the day. For some patients, it's much worse at night than it is during the day. And some patients, it's much worse seasonally than it is during other parts of the year. And the times where I've learned that itch can become exacerbated are with healing, with just air drying, so as the skin's just drying, during periods of infection, different types of dermatitis, which may be eczema related or contact related, and then medications, particularly morphine-like drugs like the opioid medications, can make itch worse. And as I talk and sense where a family's at with what they're experiencing with their child, I'll usually bring up the anticipatory guidance, or actually have to bring up right away which of pain and itch is already or going to become constant. So when does pain cross over from becoming when there's a direct or visible stimulus or historic stimulus, so a trauma, a real bad kind of affected area, and when does that cross over into pain that's constant all the time without something that we can identify? And same with itch. When does it cross over from something that's identifiable to itch that's constant all the time? And as I've learned and I've seen, pain begets skin changes, which then causes itch, which causes skin trauma, which causes pain, which then cycles and cycles and cycles and cycles. So stopping this vicious cycle with medicines alone is very difficult, as I'm sure all of you know. The way I frame my general overview and approach to medications and their usage for pain and itch relief in epidermolysis bullosa is I consider it very simplistic. I feel like the parents and their kids who I take care of know much more about EB than I do. The way I think about the medication approaches is, am I seeing a patient who has a type of simplex, a type of junctional, or a type of dystrophic? And I always think about which sort of level of skin are those defects occurring at. Are they at the more basal sort of level? Are they at that what I consider mid-level between the basement membrane and the basal level? Or are they in the dystrophic category where it's more towards the dermis level? And the reason why I do that is because that helps me to decide based on prior experience. I've probably read about 17 to 18 articles on epidermolysis bullosa in kids. There's a chapter out in a new book called Interdisciplinary Pediatric Palliative Care. That's about it. Everything else I'm saying to you is from taking care of kids and talking to families. And as I think about the different types, when I'm meeting a patient for the first time, these are the medications, classes, frequencies that come to my mind. Now, this is very much a generalization. I've had patients who've had junctional EB who've received no meds or just Tylenol. And I've had patients who've had simplex maybe I've tried anesthetic medications on. So take this with a lot of skepticism. But in general, this is how I think of where I'm coming in with what I'm going to start. And when I'm hearing about a patient's regimen, this is where I'm thinking about where the child is on spectrum of medications that I'm thinking. So just to say, simplex has needed Tylenol, perhaps has needed opioids, dystrophic, the above, what I'm talking about is simplex, plus possibly a long-acting pain medication such as methadone. And then for junctional, when I hear about a patient with junctional, I want to know that they've been getting medicines for dressing changes and there's a very low threshold to start medicines around the clock for pain. I want to be convinced actually that they don't need pain medicines around the clock for pain because it's so severe in my experience. So that's how I think about children that, again, just when I'm hearing about them for the first time on the phone, the different patients. Some of the questions that came through, you all really wrote really excellent questions, was how do we assess or measure pain in newborns? And the general rule for any child who's not going to communicate their pain is that we have to rely on behavioral or observational type scales. So this is the basis for the premature infant pain profile, which I did upload to the Dropbox, so it'll be available to Corinne and all of you if you're interested. Examples on the left of a quiet and asleep infant, and then examples on the right of acute pain. And you can see that some of the features of the forehead, and some of the features of the eye, what we call the furrow between the nose and the mouth. And those facial expressions have been found to be more specific to pain than other sorts of agitation, irritability, and hunger. In addition, the younger the gestational age, meaning if they were born early, the more susceptible they are to pain is, the less able they are to suppress pain. And counterintuitively, a child that's this age, a newborn who's asleep, may have some degree of pain. So during a painful procedure, if a premature baby or infant goes to sleep, they may actually be experiencing pain. And also with heart rate and oxygen saturation, the oxygen saturation can counterintuitively decrease. Makes sense, I think, probably to most of you, because you know that the blood vessels are going to constrict during the painful stimulus. So this is one example of how to measure pain in a newborn. Again, I think we get a lot more referrals right out of the newborn nursery and the NICU, and it's important to have the hospitals, even the community hospitals, ready to measure pain. Another scale to look at pain in children who can't communicate is the FLACC, Behavioral Pain Scale. It's called the FLAC. I also included this in a more detailed way of instructions, for example, for your providers who maybe don't use it. It scores from 0 to 10. And what's most helpful about this is if it's used in conjunction with what's going on for the child. The clinical, what I say, context, this is known to be painful, we're doing something to alleviate pain, and we're going to use this scale before and after, in addition to what the caregiver knows the child shows as painful. So that in conjunction with this can be helpful in terms of a pre and a post scoring system. This Faces Pain Scale Revised is not for comparing to the child's face. It's for the child to pick the face that represents how much pain they have. So the way the script goes, and again, this is in your Dropbox too, if you want to share it with people who take care of kids in your community with EB, these faces show how much pain there is. This face shows no pain. This face shows more and more and more pain. This face shows the most pain. Point to how much pain you have right now. And you can have the child nod their head or shake their head. You can point with them, or they sometimes will reach out. Sometimes it takes a couple times for them to catch on, but I find these faces work much better than the Wong Baker that you know are more cartoonish and have the tears coming down and the big smile. And a lot of people just ask that question wrong. They say, if you're over here, you have no pain and you're happy, and if you're over here, you have a lot of pain and you're crying. And it really doesn't fly, particularly for kids who have pain over and over and over and over. And then I always like to remind people that if you're using the numeric scale, you really need to say 0 out of 10, not 1 out of 10. You need that 0 because it's no pain, and 10 equals the worst possible pain. And I discourage trainees, folks I'm working with, to disagree with the patients on their number. It's just a number. Take it into context, not an opportunity to get into our patients with, it doesn't seem like a 10, it doesn't look like a 9. There's lots of components besides just the number that they pick. It's not the end all of pain. Oftentimes if we're asking this question, we already know that what they're going through is very painful. So if they minimize the pain score, if we think they put it higher than it is, it's not a good point of disagreement within whatever we're doing. So take it at face value and move on. And I really discourage people from asking the question, how bad is your pain? It's like if someone just cut you right here and giving examples. No, it's just, this is the worst possible pain, 10, 0 is no pain. I've heard it asked in very graphic ways that just are really, I just don't find helpful at all. This is an example of an itch scale that Tracy identified from a burn physician down in Galveston, the hospital there, burn unit. You can tell it's kind of SpongeBob-ish. I believe SpongeBob is still on television a bit, yeah. So it's 0 to 4. You can try it. This is included in our slides, so you can check it out. You can also use 0 to 10 if you wanted to with itch. There's nice descriptors here at the bottom for you all to use if it's helpful. It's not a validated scale, but when we went looking for an itch scale, that's what we found. It's in the textbook. It's published, so there you go. This is what people are usually most interested in talking about, what drugs they use for pain, should they be using for pain, what doses. How am I on time? I never really got this to work. Do you know how I am on time? We've got plenty of time? Okay, good. I already mentioned Tylenol. Just a couple points, though, about Tylenol. It's a very weak analgesic for the types of pain we're working with in epidermolysis bullosa for the most part. And it takes about 40 minutes to have any sort of real strong impact. So I find, again, by the time patients have gotten to me, I'm usually counseling people to make sure they're not exceeding the maximum daily dose for Tylenol more than anything. Frequently we use it in conjunction with drugs, but if someone's seeing me for poorly controlled pain with epidermolysis bullosa, it's unlikely that I'm going to be prescribing Tylenol alone. Ibuprofen or Motrin is really up to the other doctors and family in terms of whether the risks of bleeding, of stomach or gut complications are too much. I find that it's very patient-specific and doctor-specific, and also how frequently it's being given. Some patients have anemia, some tend to have other types of bleeding issues, and in those cases you probably wouldn't use it at all. In other cases where maybe those medical complications don't exist, ibuprofen a couple times a week really does have more of a pain-relieving effect than Tylenol. The short-acting opioids that I usually talk to families about relate to morphine and oxycodone liquid. Anecdotally, story-wise, people find codeine constipating, nauseating, and that it always comes with Tylenol. So you have to keep track of how much Tylenol you're giving. So I tend to prescribe morphine or oxycodone or a drug just by itself. One of the issues, though, that comes up when I bring up morphine or oxycodone is that people get real concerned that I'm going to make addicts out of their children. They get really concerned that I'm going to make their children fall asleep. They're worried about why I even know how to prescribe this medication for a 6-month-old. We try to work through those concerns and emphasize how painful the condition is, how serious the pain is, that it's real, that it's not just a behavior or just anxiety, that not treating the pain, in my opinion, and in the literature, is much more damaging to the nervous system than using prescribed doses that are done by a physician with a specialty in the area before the dressing changes. And what I emphasize is that even if we prescribe a decent regimen, perhaps of Tylenol and a short-acting medicine like morphine, it's really only partially going to alleviate the pain of the child. Their dressings, their skincare, everything else going on in their life, in terms of how they're managing their pain, is going to have an effect. So I try to address the addiction question up front. In terms of other, this is where I'm talking about kids who probably get anesthetic type drugs like propofol or ketamine, or things closer to what we used to call conscious sedation like Versed or anxiety relieving drugs in conjunction with pain medicine. And that's usually done in the hospital, occasionally transferred over to home. But when I talk about other medicines for acute pain relief, that's the category of medicines I'm talking about. Drugs used in anesthesia, which are used during very, very painful dressing changes. The long-acting drugs that I use in chronic pain are mostly methadone or Oxycontin. Does anybody have patients or know of patients who are on methadone? You raise your hands. Yeah. Has anybody heard about that as a medication, methadone? Yeah. Again, I get a lot of concern from, rightfully so, from clinicians and families about the usage of methadone. Patients with junctional, I'll usually start talking about it very early on in their course if I see that the children are having breathing symptoms, or I can just tell from nurses or from observation that the babies can't even be held because they're in so much pain just from being held and swaddled. Methadone is a potent pain medicine, not just because it acts like morphine, because it works to decrease some of the pain derived from our nervous system, and because we can usually keep it at one dose for longer than we can our typical morphine-like drugs. And then the last thing about methadone is that it comes as a liquid, so I can prescribe really tiny doses of methadone to patients who are only 7-8 pounds. And use it in a very precise way. The antidepressant medicines, I wish that's not how we had to call them. They really are becoming more as much anti-chronic pain medicines as antidepressant medicines. And it's a very difficult thing sometimes, I think, for families to think about the pain being quote-unquote real, and me talking to them about having a psychiatrist prescribe an antidepressant medicine for chronic pain, because those two statements seem to contradict themselves. Both mood and chronic pain work on many of the same tracks and the same receptors in the brain. So if we see that chronic pain might improve with a medicine that happens to be used depression, or vice versa, the brain can't tell the difference. The child can't tell the difference. It's a label. So if I see chronic pain that I'm finding very difficult to control, that's something I'll frequently bring up with families as well. The drugs for itch. The antihistamines really just work by making people sleepy. There's really nothing magical about antihistamines. The typical ones are Benadryl, Atarax, and I'll go over some examples of those medications. There's not many bugs in this place. It's pretty remarkable. If you've noticed that, don't just keep out the rain, they keep out the bugs too, except for this one. I'll get rid of it for you, Tracy. Yeah. The anti-seizure medicines, I think a lot of people have started using Neurontin for itch, mostly because there's probably something about the inflammation, the infection, the chronic irritation that generates itch in a more nerve-generated way. And then there's other medications that people talk about that I've had mixed or no success with. Nausea medicines like Zofran, daytime anti-allergy medicines like Claritin. When itch becomes there all the time, frequently a first step is to administer the antihistamine regularly, to give the gabapentin or the Neurontin anti-seizure medicine regularly. And some patients and doctors will talk about the use of an anti-anxiety or an antidepressant if the itch becomes a behavior, particularly if it becomes a compulsion, which I've seen and certainly heard about as patients get older, that it is an itch, but it's also a self-soothing behavior. So we'll sometimes talk about the use of that type of drug for itch. So I think these are my last kind of examples, and this is 4 groupings of medication combinations that I was basically put together as examples for all of you as pretty typical drug-based treatments. Number 1 being what most patients come to me on, or what clinicians will typically start if they have maybe just a reference book in front of them and no other background in pain. The patient will come to me, or I'll hear about them, and they'll be on Tylenol, Benadryl, Tylenol with codeine. And that might be for a patient who has very severe pain, and it might be for a patient who has very little pain and itch at all. But that's the typical referred regimen for, I'd say, many patients when they start out. Number 2 being Tylenol or a stronger anti-inflammatory Motrin, the substitution of the more sedating antihistamine Atarax for Benadryl. On the West Coast, it's called Vistaril. Other people call it hydroxyzine. I usually don't like to confuse people with all the different names for drugs, but with that drug, for some reason, we all use different words for it: Atarax, Vistaril, hydroxyzine. And then someone has bumped up from Tylenol with codeine to oxycodone or morphine. Number 3, usually if they've been to a center that takes care of these patients, some of the things that are tried is that non-sedating allergy medicine, perhaps the Neurontin that I talked about, and then someone's looked at trying to use methadone in as safe a manner as possible for chronic pain, and I consider that category number 3. And then category number 4 is where everything in front has gone, so 1, 2, 3, plus number 4, meaning the addition of some sort of anti-anxiety medicine, consideration of anesthetic drugs like ketamine, or even if they've been, usually it's Cincinnati Children's, or, yeah, really only Cincinnati Children's have I heard about propofol, but maybe there's other places, isn't basically the anesthetic type drug for painful dressing changes. These are some of the references I uploaded to the Dropbox. The Ouch card is from a paper I published in 2010, and it has the common references for pain assessment and also really common dosing for Tylenol and oxycodone and morphine and Motrin. So it's an easy way to just print out and bring with you or share with other people. I mentioned the premature infant pain profile. If there's a friend you have or somebody who has a baby right now with EB and you want to give that to their providers. An article Tracy and I published about a patient with severe atopic dermatitis, but has a lot of really rich descriptions of non-drug-based therapies for her itching. And then an article I published with Dr. Morell and some other folks at Columbia about using an anesthetic for dressing change in a patient who had epidermolysis bullosa simplex. As I said, there's the Q&A with me tomorrow where we can get into more details, more doses, more of your experience and stories. I hope you'll bring your frustrating, positive, and negative experiences to that round table so that people can hear from each other as much as from me. So that's in the Emerald Bay meeting room tomorrow at 2. We're going to save questions to the end, and I'm going to have Tracy take over.
Hi, everyone. I'm going to talk about the integrative piece of the medical and integrative presentation. And when I talk about integrative therapies for the purposes of this talk, I mean mind-body therapies primarily. John and I were talking about how to make this most effective. Oh, thank you. Big difference. And really help you to understand how important the mind is in the body's regulation of pain and itch. because pain really is a mind-body experience. Absolutely, we describe it as something with a cognitive, or thinking, how you think about pain, so a cognitive dimension, an affective dimension, or how you feel about it, your emotional response, and of course the physiological part, the perceptual part of pain. So what I'd like to start with is having you just get as comfortable as you can in your chairs. And if you like, you can close your eyes for a few moments and relax. Or if you prefer, you can just let your gaze fall to your hands or on the table in front of you. And we'll do a little mind-body exercise. So I know that it's really quite cool in here, but it's very, very hot outside. And because in our minds all things are possible, you can use your senses imaginally to really get into the experience of imagining you're in a very warm environment and perhaps a little bit thirsty, perhaps craving something refreshing to remedy that situation. So imagine now that someone has handed you a nice cool bowl of lemon sorbet, a cool refreshing bowl, and you can even imagine taking your other hand and holding the metal spoon and noticing that it too now is very cool to the touch. And perhaps you feel yourself getting a little thirstier, leaning forward and smelling the sorbet and how kind of sour and sweet it is. Perhaps your mouth waters a bit as you lean forward and take a nice big spoonful and place it in your mouth, just on the front part of your tongue. Don't swallow it yet, but you can notice if there's an urge to swallow. Feeling as the ice becomes more liquid rather than solid and spreads out over your tongue, feeling the little bits of lemon rind. And you can now swallow the ice, feeling as the cool sensation moves down your throat and perhaps into your stomach, alleviating that feeling of heat and that thirst. And you can open your eyes. How many people were able to have some sort of sensory experience, either feel the cool bowl in their hands or the ice in their mouth? Okay. Anyone kind of taste the sour, sweet sorbet a little bit, or notice themselves becoming thirstier? Okay. Or feel it when you swallowed it and notice any tanginess or watering in your mouth? A few people. Okay, you'd make excellent hypnotic candidates. And that's one of the therapies I'm going to talk about. But again, that was a really brief, simple exercise, and shows you that your mind and your body are quite linked. So what I'm going to talk about is not drugs for pain. And these are therapies that can be used quite well with the medical therapies, drugs, or procedures. And we really do think that these offer the most powerful way to treat pain and itch, as well as the anxiety and other mood symptoms that often accompany pain. So I'm going to talk to you today about the ones you see highlighted in yellow: mindfulness, hypnosis, biofeedback. I'll talk a little bit about aromatherapy. If there's time, I don't use it as a standalone therapy. I use it in conjunction with the others, but certainly there are a whole bunch of other non-drug therapies that can be really useful for managing symptoms of medical illness. So when John and I were talking about how can we really explain the mind-body relationship with pain and why these therapies are helpful in a way that's user-friendly, and a little bit more user-friendly than like the gate control theory of pain, which is a really good model, but it doesn't translate as well for this type of talk. I said, my husband does cartooning in his spare time, and what do you think of having him cartoon the way I actually describe pain to patients, and especially children? And if you know John, he's extremely easygoing, so he said, well, sure, why not? So I asked my husband to draw this. So when I have kids come in, I say, I want you to think about your spinal cord and your nervous system like a really narrow highway. And pain is this kind of old beat up car that's trying to get this message to your brain, but it's not really a message that you want. So that kind of 1970s Herbie the Love Bug, for people who are old enough to remember, car coming out of the brain is delivering a different message of profound relaxation or moving your awareness to something different. And it can block or change the way we experience pain, really bringing the severity of pain down and bringing the anxiety down. So why combine approaches? Medication, as you may know, is really often not sufficient. It's very, very important in treating EB, but it's not necessarily enough for everyone in terms of pain management or itch management. And because, again, pain is a mind-body phenomenon, we really want to use the mind and the body to try and address symptoms. In the literature in the last several years, there's been a lot of talk about the phenomenon of catastrophizing. It's really just a big word to describe what just about everybody experiences or thinks when they have chronic pain. So, I can't take it anymore, this is never going to get better, I feel hopeless. But these catastrophic statements, we know, actually increase the perceived severity of pain. So you might be at a 5 and move to an 8. But relaxation techniques and refocusing can help to bring down not only the perceived severity of pain, but to change the unpleasantness and help us to actually do what we need to do despite pain. So these techniques creatively engage the mind and body and help people to feel a greater sense of control. So these approaches can help with things like bath time, both the pain associated with bath time, but the anticipatory anxiety, which can start an hour before the bath. It can start the night before a bath. And some of you may see that your children might not sleep well the night before a bath as compared to days in between. It can help with dressing changes, medical appointments, sleep issues, anxiety and depression issues, which again are very, very common, more common than not in chronic pain. The pain and itch themselves, and also increasing the ability to tolerate frustrating situations. So the first thing I'm going to talk to you about is mindfulness, or mindfulness meditation as it's known. Does anyone here have a mindfulness practice or know what I'm talking about? Some people? Okay, fantastic. It's one of those things that I find I have a very hard time explaining well. It's almost like you have to do it to really get it, but it's present moment, non-judgmental awareness. So I ask patients to think of their attention as their gaze and imagine that pain is something really loud and really obnoxious, trying to get them to attend to it. And the more we focus on pain, the more amplified it seems to be. It's kind of like having different actors on a stage and one of them really hogging the stage. And what we can do by training somebody to move their awareness to a neutral sensation, like just observing your breath or some other type of experience, we can really change the experience and decrease the unpleasantness. So I have a dish of shells on my coffee table, and I'll often ask a child to pick up one of the shells and ask them to take it in with all of their senses and really move their awareness to that shell. How it feels, how heavy it is in their hands, the colors of the shell, the texture. I'll say, does it have a smell, which is something people think is strange. But when you're really focused on one thing, it's very hard. You can't completely attend to something else, including the pain. And I love brain imaging photos because I think they explain even better than I can that mindfulness is actually a different state than just resting. So if you look at the column on the left, even with pain present and rest, you'll see that there's quite a bit of activation in the brain. On the right, mindfulness meditation. This was a trial where people just learned meditation for 20 minutes a day for 4 days, that's it. And then were exposed to a heat probe to induce pain. There was actually increased activation in some areas of the brain and decreased activation in other areas. And so the unpleasantness decreased, not just the severity of the pain. So I like to ask people if they know anything about hypnosis, if anybody here has done hypnosis or listened even to hypnotic audio programs. Okay, Did you find it helpful? Oh, I'm so glad you said yes. I love this kid because if you Google either googly eyes or hypnosis, this is one of the photos that comes up. And I like to say this is one of my star patients who right now is cleaning his room without anybody asking him to do so. Has anybody heard any negative kind of myths about hypnosis? Anything scary? Lots of times people say, I want to do something non-drug, but I don't want to do hypnosis. And I'll ask them if they know what it means, and they'll say no, but I know that I don't want to do it. And really, hypnosis is, oh, here's some other scary images. There's always like a Bela Lugosi vampire type of character saying, look into my eyes, and then you know you're going to do something that you really don't want to do. In this case, this guy's holding an eyeball, and he wants you to look into it, and then you're clearly going to be clucking like a chicken at work until somebody tells you to stop doing it. But hypnotic states or trance states are the most natural things in the world. We all move in and out of hypnotic states every single day. Even the most logical person who says, I don't go in and out of trance. You might be in trance now. So an everyday example, when you go to the movies and you see Harry Potter and he's playing Quidditch and he looks like he might lose or drop the ball and we get anxious, or when clearly he's winning and we get really excited, or maybe he's even having a romantic scene in the later Harry Potter movies and we feel very mushy in a good way. Well, that's a trance state. You're sitting in a seat next to strangers potentially, looking at what's essentially a fabric screen populated by colored dots and lights. But you're having an emotional response and you forget that you're looking at just a two-dimensional image. Well, that's trance. When you're driving, or even if you're a passenger, 5 minutes might go by and you might be thinking about a conversation you had with someone or one you wished you had. I'll be thinking about this presentation later. You might be remembering a party you were at and the clothes you wore and the birthday cake you had and even tasting it. Another part of you is driving the car that whole time. And if a squirrel ran across the road, hopefully you would be able to stop in time, and you probably would be. But another part of you is engaged in trance. Same thing for the runners in the room. I know there are some runners here. There are times when a run feels 8 times as long than it really is, and other times where it feels like it was over in a moment, or you don't even really notice a landscape around you. Well, that's a trance-inducing activity. So it's just a state of intense inner focus. People help you, a trained provider can help you to get into that state by using techniques like symbols and metaphors, because your unconscious loves that type of language. Repetition of words, voice tone and pacing. And children are actually the best hypnotic candidates because they're so imaginative. They move in and out of trance states all the time. They don't have to be completely out. They can be, but they can also be moving and playing and dialoguing with you. It's a collaborative process. A trained provider is going to work with you to find out what your goal is. So there shouldn't be any surprises. And you can do at-home practice just on your own or with an audio program. And it's been shown to help with a variety of pain conditions, not just the itch and pain associated with EB, which is what we're here to talk about today, but headaches, can help people quit smoking, adopt healthier eating behaviors, shrink warts, and this is actually true. There's a lot of data out there on wart shrinking for some reason. It can help with mood issues and self-esteem issues and fears, especially fears of flying, etc. So another imaging slide. This is from a study where they actually hypnotically induced pain, which I don't do with anybody, but I just wanted to show you on the left is physically induced pain. What you'll see in the center with hypnotically induced pain is that it's not exactly the same, but there is some overlap between the areas in real pain versus hypnotically induced pain. And this is different from just simply imagining. It's a much more intensely focused state. So with EB, obviously there are some negative associations to water, especially around bath time. And with the patients I've seen people have significant improvements both an anxiety related to bath time as well as itch and pain. And one young boy wanted to imagine flying over Niagara Falls. It's somewhere he had been with his family. And he imagined holding his family's hands and flying over Niagara Falls. And I asked him to imagine the spray of water touching his skin, which at first he was like, no, I can't do that, it's going to burn. But with a few sessions, we were able to change the association of water, of this spray, to magical water that was very soothing and calming and healing to his skin. And another journey, we went on an imaginal journey with him swimming in the ocean through magical water, and his two cats were able to make an appearance as fish who could help him understand what would soothe his skin and help him to do better at bath times and at night. And his mother reported that he had his average pain and itch and anxiety go from 5 out of 5, we used a 5-point scale, to 3 out of 5 during some bath times and 0 out of 5 at other ones. And there were several instances where he had no pain and itch, no anxiety relative to the bath, and this was without changing his medication. Biofeedback is something that can be really wonderful for kids. For EB, the only biofeedback modality that I would recommend would be skin temperature biofeedback. And basically, via a painless sensor, which you can attach with Methadone, you can show a child when they're in a relaxed state versus when they're in a really anxious or painful emotional state. And this works because when we are stressed, our blood vessels constrict. And you'll notice a nearly immediate decrease in peripheral skin temperature. And conversely, when someone is able to use their relaxation tools, we can help them to get better and better at it. And you'll see a corresponding increase in skin temperature, again, nearly immediately. And so there are at-home devices you can order pretty inexpensively. And again, it shows person how they can control their physiology. And this is really like developing a muscle. The more you do it, the better you get at it, and the more quickly you can elicit a relaxed response. Typically short-term, it's useful for a lot of non-pain and pain conditions. The skills are practiced at home, and it's often paired with other types of mind-body therapies. The last thing, I don't really have time to talk much about it, but aromatherapy, there's some research, there needs to be better research showing a relaxation effect and a sleep-inducing or a soporific effect with some aromatherapy oils. I tend to use these, I just ask a child to pick a pleasant scent if they like and pair it with the other therapy of their choosing. In cognitive behavioral therapy, we would say this is higher order conditioning or second order conditioning, because over time, even just the presentation of the pleasant scent will elicit a more relaxed response. So again, non-drug options, mind-body, complementary and alternative medicine therapies, these are different ways we can refer to integrative treatments and pair them with conventional medical care for what we believe is the most effective way to address pain and itch. And so here are some resources for you about the therapies that I mentioned. You can also go to my website. I have some articles on the various therapies you're welcome to read, or you can follow me on Twitter. I post things quite a bit on pain and mood and complementary and alternative approaches to managing these. So that's it. Thanks.
It's actually 3 questions, but I'll ask it as one in 3 parts. One, just as a general question, why is there no medication for itch? Just speaking, because all, as you said, itch medications seem to be just make people drowsy. So is there something in the pipeline that could address itch? 2, when it comes to just pain for bandage changes, can you use something like lidocaine or something that would be effectively anesthetize the surface, even if temporarily? And then the last thing is, for people who use hydroxyzine or Benadryl, are there long-term side effects of being on that beyond just, I guess, tolerance?
Good questions. The first one was, is there something in the pipeline that's more effective for itch that doesn't have the sedating effects of antihistamines. Kim, do you know of anything? Dr. Morell's a pediatric dermatologist at Columbia. I don't know of anything. But there's no trials, right? No. The second question was what?
Using something like lidocaine or something.
Oh, right. Thank you. Yeah. Most of the topicals, like lidocaine or pain medicines like morphine and other ones, are avoided in epidermolysis bullosa because the skin barrier, particularly in the areas where the children need it, aren't completely intact. So in particular in children, and the younger the children, the more the worry is, the absorption of things that can be toxic to the heart in terms of arrhythmias is not known. Blanking on her name, it's referenced in our article. In the UK, United Kingdom has written about topical morphine gels for the pain receptors. And I've talked to people at Cincinnati about that, and they didn't report as much success as the teenagers who had topical morphine underneath their dressings in that article. I've used topical morphine gels in patients with decubitus ulcers after their wound surgical kind of treatment is over with good success, but I haven't crossed over into trying it with epidermolysis bullosa patients. It's really a group decision that's made by the providers and the family, and needs to account for the fact that we don't really know how much of the drug the patient's going to see. And then the third question was
long-term effects besides tolerance to blood drug.
I don't know. I don't know if there are. I mean, I talked about that quite a bit in the article I wrote about ketamine. That patient was on ketamine for dressing changes for almost 2.5, 3 years. I haven't looked at the literature about, the question is are there long-term side effects of using Benadryl or Atarax frequently for year after year after year, learning, other developmental effects? I haven't looked of whether there's other literature on it. Anybody in the room know about that? I just haven't. I haven't even looked.
I heard a rumor that it was linked to Alzheimer's possibly from the paramedic, a friend of mine, and she's done a lot of research. And that might be a possibility.
So a paramedic friend said that there was a possibility that, and what was that based on?
Take Benadryl and histamines for a long period of time.
Could you ask him maybe where he read that so people could share it or look at it and find out what it was in? I've never heard of that at all. Yes. Does anybody have any comments just on that point? Because it's an important one that's, I'm sure, concerning to a lot of parents that I don't want to just let go. Do you have any comments on that particular point related to Benadryl and long-term effects? Has anybody in the room searched that or done a more formal look at whether that's a concern? Yes.
I've used Benadryl since it came out, and I was always told by the people who recommended it to me that it never had any effects long-term.
Yeah, and I mean, I'm unable to really say anything about it. I just don't know. Kim?
Just warn people that they're not too sedated during the day. We need to be alert and learning and doing other things. But generally, also, if you don't get a good night's sleep, then you're not also going to be alert during the day. So you just oftentimes will do a higher dose in the evening to get that sleepy effect, healthy sleep through the night, and then a lower dose or less during the daytime so you can be alert in daycare or school.
My guess is the only way something like that would be studied formula in a very methodical way would be a drug company would have to look at a first-generation antihistamine, which I think is very unlikely. They've only looked at second-generation antihistamines that are non-sedating, like Claritin and Zyrtec, and have a long-term data population like people did with Celebrex and Vioxx. The only reason the FDA put a black box warning on every single anti-inflammatory that all of us take, ibuprofen, naproxen, blah, 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 was because they followed patients taking Vioxx for long enough, and they originally doubted the data that there were more cardiac problems in those patients. And then when they continued to follow those patients, they realized there were more cardiac events. And then the warning went out on every, like just going to the store and buying Advil, now you have to basically read a warning that you could have an unexpected cardiovascular event. So my guess is that, like so many other pain medicines in children, the itch medicines have very little to no incentive for someone to do a broad enough study going into the future or prospectively to make that at all worthwhile to actually just do. Yes? Oh, we don't have any more time for questions? All right, well then, please come tomorrow to the family meeting, and Tracy and I will hang around here for a little bit. Sorry.
I was just going to mention that.